OSWB symposium. The theme of this session is Survivor of the Storm, Overcoming Difficult Situation in Ophthalmic Surgery. So may I invite the chairperson, Dr. Parthavishas is yet to come. Dr. Sharaj Bhattacharya is there. You can come on the stage, sir. Let me invite Dr. Pinaki Nag, Dr. Arup Chakraborty, please, sir, co-chairman. And invite our panelists, Dr. Pinaki Nag, Dr. Swati Agarwal, Dr. Shagnik Shurjadas, Dr. Oyan Mahanto. Okay, they will join soon. Let us start the program with the first topic. Dr. Rupak Biswas will be presenting Divide and Conquer. Over to you, Rupak da.
ऑडियो भी चालू कर दीजिए। वो नहीं आया। इसको डालिए। Can I just have a small request? Can I just request Dr. Anil Mandal sir to be on the chair, please, sir? So it will be our honor, sir. Please, please. And at the same time, I'll request Dr. Ratish Chandrapal also to be on chair. Sir, please. नहीं किस पे जा रहा है आप? कौन सा वाला? E drive backup. नहीं E drive नहीं इसको D drive था. कौन सा वाला ओपन किए हैं आप पहले वापस जाइए। बैकअप फोल्डर ये हुआ है ना, उसके बाद डी ड्राइव बैकअप है, उसके बाद AIOS 20 ये वाला, इसको स्टॉप कर दो। Not that anti-segment surgeons, they do divide and conquer and they always overcome the situation, but sometimes if situation comes like this, that even posterior segment surgeons also need to play a role of divide and rule or divide and conquer kind of situation. So this is a story of one-eyed old gentleman. Done? This is a very old video, I mean almost more than 10 years back.
However, we should be prepared to face them.
Sound.
Our story also begins like this. 62-year-old high myopic gentleman presented to us with traumatic subluxation of IOL, retinal detachment and choroidal detachment in his right eye. He was operated for retinal detachment surgery and choroidal drainage with silicone oil injection and had a successful post-operative period with good visual recovery. But something else was waiting for him. His vision started dropping due to corneal decompensation because of silicone oil touch. But the oil could not be removed for the risk of recurrence of retinal detachment. So we had to find a way to prevent the corneal damage while keeping the oil inside. And we came up with this innovative idea of forming a barrier. 2 side ports were made. AC reformation and synecholysis was done, during which oil droplet was seen going in the vitreous cavity.
10-0 suture was passed from limbus and taken out at 100-degree opposite limbus and spanned the cornea horizontally. Similarly, with another proline suture, we spanned the cornea in vertical manner. And a criss-cross mesh was formed over the iris plane. The strings should not be too loose or too tight. The final knot under limbus was buried under conjunctiva. The visco which was inside was washed and side ports hydrated. Thus, a barrier was created by weaving a mesh with 10-0 proline suture above the iris plane. This mesh compartmentalized the anterior and posterior chamber. A widthful decision can save you at that point from being drowned.
So 1 year
This
later,
video thus demonstrates how this innovative method can prevent silicone oil related complications in aphakia. Thank you.
1 year later, I removed oil and the silicone mesh as well, and this gentleman is still under follow-up with me and happy with aphakic glasses also.
Thank you, Rupok, for this excellent concept. In the primary surgery, was
Should be prepared to
inferior PI was done to
Yeah.
prevent the migration.
Yeah, it was actually a traumatic mydriasis because of that, so it was not there, but it was the inferior PI was done.
Generally, that is the standard procedure we do to prevent the migration of silicon oil in the
So
anterior.
this eye was actually acting like an aniridia eye. So because of that, but initially when we filled, it was staying there. But over a period of time, slowly the oil bubble has started moving up whenever he was, sitting position, and causing actually the residual amount of the iris was causing a iridocorneal touch. That's why the synechiolasis was also done, and the IOP has started going up because of that.
Another question, like you have put a mesh. So instead of doing a mesh, because yesterday also somebody showed a similar procedure, he just put a crisscross in 4 corners. So, is it good enough to prevent the oil to?
Yeah, this was long
Because
back.
it's
Actually,
a bubble. It's a single bubble. You have to prevent it.
correct. So it depends upon how big is that. It is actually there are literature report which shows that even a 12 to 16 square is more than enough to prevent it, because the silicone oil, if you have a 5,000, then even you can make a little less number. If the size of the square is sufficient enough with the surface tension to prevent it off. So probably 12 square is good enough to prevent it. 1 or 2 or crisscross may sometimes can prevent it off, but again that may be chance of luck.
It's only one situation we cannot. This condition cannot be helped. That is, if the oil is emulsified.
Yes. So then you have to take it out.
Great talk. Can we have the next?
Yeah, next we'll call upon Dr. Rudra Prasad Ghosh, who will be speaking on taming an Argentinian flag. Rudra has to go north to tame another president probably to prevent war, but he is with Argentina now. Four minutes is your presentation.
Yes, yes. नहीं साउंड चाहिए.
Hydro dissection. When the going gets tough, the tough gets going.
Yeah. Thank you, Chairperson Scientific Committee and Office Bearers of OSWB for having me in this session. So I'm going to present my topic, taming an Argentinian flap. Basically, this video was made for a presentation where the topic was when the going gets tough, the tough gets going. So I'm starting my video.
There's a saying, when the going gets tough, the tough gets going. So, and that term is aptly applicable in this case. A routine hypermature cataract, which I started doing like another routine case. I usually stain my hypermature white cataracts with Trypan blue, and also did the same thing in this case. I thoroughly washed the Trypan blue and put some viscoelastic inside the anterior chamber and started doing with a cystito. Oh my god, this shouldn't have happened. You can see an Argentinian flag sign. So this has been extended from 12 o'clock to 6 o'clock. Now the rescue operation. I started doing rescue my rexis on the left side with the help of a forceps and started doing on the opposite side by a cut with a micro scissor. And tried to repeat the same thing, but again it started to extend, which I completed with the help of an age-old 26 gauge 62. I did a controlled hydro dissection, put some high viscous viscoelastic, and started my phaco with my usual grater and chop technique. I tried to do a crater in the middle of the nucleus and tried to break it from the periphery with the help of a sharp chopper. I did the phaco in a bit supranuclear or supracapsular position as I tried to avoid the stress on the zonules and stress on the torn flaps. And I repeated the same maneuver in all the other quadrant of the nucleus. You can see some fibers are very leathery, but I still managed it and completed the emulsification with the help of my own technique. Did some OVD inside the anterior chamber before doing a irrigation aspiration of the cortical matters. Bimanual irrigation aspiration done in a very controlled manner, avoiding the torn flaps. Cleared the capsular back of all cortical matter. And then I put a single piece hydrophobic IOL, and it was also inserted in a controlled manner so that the stress falls minimum on the torn capsule. thus the tough is tamed at the final.
Before starting the discussion, I want to submit that this is not an grammatically, may not be an grammatically correct case. There are other techniques.
There is a saying, when
There are other techniques of doing a white cataract, especially the rexis, but I tried it my way, and at the time when there was complication, I had to manage as per the available resources I had. Thank you.
Thank you. Pinakida, would you have done anything different for the initiation of the capsulorhexis? Please keep it short because of the time.
Yeah, I would done totally different way, because now for last 4 years what I'm doing just puncturing, but there is quite a few small tips I'm just going ahead to tell you about. Just don't use the 26 gauge, use 23 or 24 gauge needle, use with a glass syringe with a very loose piston, and also you, when you puncture, you put the bevel edge down, not in the center, just away from the center, not in the center of the lens, but away from the lens in the mid periphery region. And you, before you puncture, you start sucking. If you remember these four things, very 99% cases you will get away with it. You will have enough time to complete whatever way. You just once you puncture, you keep sucking, as well as you tap the nucleus down so that the fluid which is trapped behind the nucleus also comes up, and you can suck most of it. And then you go ahead and do normal rexis. And also with
So main aim is to decompress the intranuclear pressure.
But the fraction of the second is very important. That is the most.
Sucking before puncturing. Start sucking before.
I like to say, when it has happened,
Next.
now no way out. Now while doing, before proceeding for the phaco, we must look for few things. Number one, a skill of the surgeon like Rudro, Dr. Rudro is definitely it's 3+, and after that, whether this is a hard cataract. Without any ego, we must look into it, and we must look for the flap motility sign. That's while just putting some BSS, we can see the motility of the flap. That shows whether it is extending or not. If it is not extending at that point of time, I think we can jolly well proceed.
But sir, in some cases, in spite of
the pupil was bit smaller, so it would have been difficult to see the flap motility.
Yeah, we'll use some maneuver to make it dilated, because unless you see it, if you go blind, then something wrong might happen.
During the during the No, what Swarajda is saying, to inject some BSS, to inject some BSS to see the flap motility problem.
Yeah, just little bit of rotation, this can be elicited.
Ruth, is there any comment?
Not rotation, just to see.
I think here we are dealing with an intraoperative situation where intralenticular pressure is high compared to the pressure in the anterior chamber, and high viscosity viscoelastic should be put adequate so that the complication may not happen. And with the syringe, the other was telling, you don't go into the center, probably in the periphery, and as and when you just puncture, try to aspirate whatever little fluid cortex or whatever can be aspirated. That equalizes the pressure, and chances of this type of complication may not be totally negated. At least the incidence of this kind of thing happening can be reduced.
Actually, one point I want to add, in all these cases, I use a 1.4 or 1.8 sodium hyaluronate. That helps me a lot. And this particular case, at the start of the presentation, I told this was not a standout one. This was a case where I faced this complication and I tried to manage.
Normally, but the use of cohesive OVD, now it has reduced.
So, use of cohesive OVD, the
Means
making of the rexis flap is
Yeah,
bit
sodium
tougher.
and the incidence
Not
of
chondroitin sulfate, only
argentinium
sodium
has
hyaluronate.
been reduced now.
For the sake of time, we'll take a comment from Swati.
Yeah, A very well done, well managed. Just the excellent surgeon you are. You can use a microrhexis forceps also with your left hand because you've used the microvanous scissors. So your rhexis was running out from the right side. That wouldn't have happened. And the bulky nucleus, one shouldn't take out the whole thing. They should break into pieces so that the stress on the cut margins are lesser. But overall, a very well managed case and great. All claps.
Thank you.
Thank you, Rudroda.
Rudra, one last question. How did you ensure that your IOL was in the bag? Because your pupil became small and we didn't see that you were moving the
Yeah,
iris.
this is an edited video.
Okay.
In between the video, I retracted the iris with an iris retractor and saw that the haptics are in an horizontal plane.
Okay.
My extension was in the vertical plane, and that's why it was in the bag.
Comment.
Last question, is a roll up mannitol, IB mannitol before that?
No, I don't use. Most of the people don't use that.
So we'll call the next speaker.
No.
Amitav.
Next, we have management of sympathetic ophthalmia by Dr. Amitav Kumar.
Yeah, we have it.
So anterior capsule massage, I think, is a very, very relevant thing. The loculi do exist. It is loculated liquid cortex, and we must attempt to break loculated cortex, the loculi. Then you have a better handle. You are creating a common pool because when your capsular axis reaches a tense locule, it is going to run. So if you have a kind of equalize the pressure all around, you do have. I have a wonderful video which I shown, and it has really it really works.
Suben, you are absolutely right. Actually, because of the constraint of time, I couldn't say that. But once you did the puncture and sucked it out and tapped the thing, and then also you come out and with the visco you just massage, get the locula out and the fluid out, then it's better.
No, what Shubenda is talking about, I showed yesterday. Before the puncture.
Shogodada, you are the moderator. Please start.
Good morning. Absolute pleasure being here, and at the very outset I would like to thank OSWB and AIOC scientific committees and Dr. Sudipta for this opportunity. So this is one storm which you might have to weather after the surgery is done, and that too in a normal eye. So I will share a case with which I saw a couple of months back, a 13-year-old girl from West Bengal who had a history of decreased vision in her right eye for the last 15 days, a history of an open globe injury a month back in the left eye for which a corneal tear suturing was done elsewhere. She had already been diagnosed as a case of sympathetic ophthalmia, but she was on a suboptimal dose of oral steroids and azathioprine. At presentation, her best corrected visual acuity was counting fingers close to face in the right eye and hand movements in the left eye, normal intraocular pressures, a granulomatous panuveitis in both the eyes, and exudative retinal detachment in both the eyes. So you see a slit lamp photograph in diffuse illumination, the left eye showing those corneal sutures, the left eye showing those keratic precipitates on the endothelium and vitreous cells. And this was the fundus of the right eye showing a disc edema and hyperemia, and inferior exudative retinal detachment in multiple pockets of SRF. An ultrasound of the right eye showed a PPCT of 1.78 millimeters in the right eye and 1.26 in the left eye. So the diagnosis was pretty evident. It was a sympathetic ophthalmia. So in view of the granulomatous panuveitis, we started her on frequent installation of prednisolone acetate eye drops along with cycloplegic, and we referred her to a pediatrician for a clearance for intravenous methylprednisolone, oral steroids, and azathioprine. And after obtaining a clearance, she was subjected to 500 milligrams of IVMP per day for 3 days, followed by a tapering dose of tablet prednisolone along with calcium supplementation and antacids, and we continued her on tablet azathioprine 50 milligram twice a day. So in a month's time, the eyes quietened. Her vision improved to 6.9 and 6 in the right eye, 6.45 and 36 in the left eye. And these are the two eyes in a month's time. She had a reactivation 4 months later, again with a reactivation, and you can see a little bit of vitreous haze and a disc hyperemia. In view of this, she was the dose of her topical steroids and oral steroids were hiked up, and she was continued on tablet azathioprine, and you see the clearing of the vitreous. She had another reactivation 3 months later when she had stopped all the treatment, and again the vision dropped to 624 N10 in the right eye with again a granulomatous panuveitis. So again we had to repeat topical steroids, IVMP, oral steroids, and azathioprine. In a month's time, again it quietened down. The reason I presented this case is, in a case of sympathetic ophthalmia, if you have either a premature cessation of treatment or a suboptimal dose of medication, then there are chances of recurrences are much, much more. So we did a study at our center on 43 patients, and we found open globe injury to be the commonest cause. One interesting finding in our cohort of patients was neovascularization elsewhere in 5% of the patient, which has not been reported in sympathetic ophthalmia till date. Glaucoma was the commonest complication, and all these patients were treated with steroids and immunosuppressants. This was a study on pediatric sympathetic ophthalmia at Shankar Nethralaya, Chennai, and again trauma was the commonest cause. They were treated with steroids and immunosuppressives. So Sun Working Group has come with a classification criteria for SO, which in case there's a history of injury and a granulomatous panuveitis, and if syphilis and sarcoidosis have been ruled out, this comes into the category of sympathetic ophthalmia. A meta-analysis of 24 population-based studies has put the incidence at 0.19%. So basically what happens is there's an upregulation of inflammatory mediators, and this leads to an oxidative stress to the photoreceptor mitochondria, and this leads to photoreceptor loss and a decrease in vision. The common causes are trauma or iatrogenic. Not only open globe injuries, but even closed globe injuries like a disinsertion of iris or a hyphema have led to sympathetic ophthalmia. And in some parts of the world, ocular surgery, especially posterior segment surgery, has overtaken non-surgical trauma as the major cause of SO. This was a study at Shankar Nethralaya, Chennai on post-surgical SO, and they have indicted vitrectomy and scleral buckling to be the commonest inciting factor, followed by cataract surgery. And even a small gauge pars plana vitrectomy can cause a sympathetic ophthalmia. The earliest reported case of SO has been 5 days after a penetrating injury. And we know once we have a diagnosis, you go ahead with imaging, and so we have non-invasive and invasive modalities available with us. And this would be OCT, which will show multiple pockets of SRF, and OCTA showing those flow void areas, and ultrasonography in case the posterior segment is not visible, then probably you would need to know whether there's an RD or not. And the invasive ones are the fluorescent and indocyanine green angiographies. FFA would reveal disc leak with pinpoint leaks and late pooling. And ICGA will show these hypocyanescent dark dots. SO may have varied presentations, and there are some abnormal presentations like a frosted branch angiitis, or you may just have a posterior sympathetic ophthalmia where there are only fundus changes in the early stages. You may have anterior segment inflammation when there are recurrences. So where do we stand as far as the treatment is concerned? Steroids form the mainstay of treatment, whether intravenous, oral, topicals. And immunomodulators, so this is one etiology where we would use immunomodulators as a steroid equivalent and not as a steroid sparing agent. And there are a gamut of these immunomodulators available, including antimetabolites, alkylating agents, biologics. And the common ones in use are azathioprine, mycophenolate, cyclosporin, and adalimumab. There are reports of long-term drug-free remissions with high-dose, short-term chlorambucil therapy with minimal long-term serious health consequences or adverse effects. How about local steroids? So IVTA has been shown to be an additional tool in the treatment of SO. Fluocinolone acetonide retisert has been used. And there are reports of use of dexamethasone implant as the primary therapy without concomitant IMT with a good control. Enucleation, evisceration, it's controversial, and with the better management options available now, this is best avoided. Enucleation has got a cosmetic disadvantage, but the rate of SO is around 0.3 to 0.9%, vis-a-vis evisceration, where you have a cosmetic advantage, but theoretically their chances of SO are more, but literature doesn't support that. The common causes of decrease in vision are active intraocular inflammation and cataract. So to wrap up, these cases need a very early diagnosis. You have to hit them early and hit them hard. with whatever is available with you. They need appropriate medications and dosage in the form of steroids along with immunosuppressives. At times you may have to use triple agent immunosuppression. Then, and these have to be used for adequate duration, and these patients need to be on a long-term follow-up because the chances of recurrences are very high. I thank you for a patient hearing.
Thank you, Dr. Amitabh. Very nicely managed case. How do you follow up this? Like, they need a long-term steroid therapy. So how do we follow up these patients, and SO can happen many years later as well?
That's right.
So what's the follow-up?
Yeah, so if once a patient reports to your office, I think, and you have started the patient on medication, and especially if they're on immunomodulation, then probably for the first couple of visits every 2 weeks, and then probably monthly, because you would need to monitor their blood counts and the liver functions as well, because you have put the patient on immunosuppressives. So to be very careful about bone marrow suppression and deranged liver functions.
Is it always you add the immunomodulator along
Yes.
with the oral steroids?
That's right.
And how long will you continue?
So it depends. I have patients who have been on immunomodulators for the last 1.5 years now. Because even with immunomodulation, they might have reactivations even after a year or 2 years.
I have a question.
Yes.
Very curious. Why you chose homatropine instead of atropine?
Because normally we use atropine only when there's a very, very intense inflammation like a hypopion. Atropine is mainly a very strong cycloplegic. Yeah,
yes.
cycloplegic. But the effect of the atropine lasts for a long time because the patient doesn't have
in line with hit them hard.
Yeah, so the homatropine does the work. So I think it causes cycloplegia, it causes mydriasis, and at the same time, it does not bother the patient much once you stop the medication, because you're putting this in the eye in which the patient is able to see. So atropine effect, once you stop it, it'll take somewhere around 2 weeks to go away.
Yes, agreed. Agreed.
So homatropine does the work.
Some of those better cycloplegia helps in uveitis management.
So cycloplegia is mainly for the symptomatic
Spasm,
relief,
the spasm.
relief of the patient. I think our patients are pretty, their threshold for pain is much, much high. I think they can manage with homatropine. Yes.
My question is not to treat the sympathetic ophthalmia. I'm not asking that. I'm asking what is your opinion regarding the continuity duration of a patient having the open globe injury?
Yes, so there are, as far as SO is concerned, open globe injury leading to SO. The earliest reported is 5 years, and it has happened even 4 decades after the initial injury. So I think initial couple of years you need to follow them up more frequently and inform them about the possible symptoms which they can have, and including loss of accommodation, because not a lot of patients may not know about it. And but I think you need to keep them on a long-term follow-up because it can come back anytime.
No, I'm not asking that. Sorry. I'm asking how long you will continue the steroids.
Oh, the steroids. So we would want to wean them off steroids as early as possible. And so by then the immunomodulators will probably start their role. So I think at least for 6 months.
6 months.
Yeah, if
yes.
they have had a reactivation, at least 6 months.
Yes. And there is the actual problem, because most of the people, they stop it either at 2 weeks or 4 weeks.
No, that's too premature.
Most of the people. No. Means this is the common practice in...
Yeah, even if the inflammation has come down, and if the patient's labs are fine, I think you need to keep them on even on a low dose of immunomodulation
yes.
for a long time.
Yes.
When do you take this call that you have to sacrifice the eye to prevent the SO? What's the practice?
Yes, so literature says it should be as early as possible and within 2 weeks. But nowadays, I think because there's a possibility that you might have the sympathizing eye with the eye having, the exciting eye having the better vision as compared to the sympathizing eye. So we did a study on around 50 patients, and I've had 3 patients who have ambulatory vision in the exciting eye. The sympathizing eye is, we couldn't save it. In this patient, yes, sir.
right? Must have taken 2 months or so to. Then you started with the, what was the dose, 60 or 80? Or
So so our protocol is we put them on IVMP for the first 3 days, and that is followed by at least 1 to 1.5 milligram per kg of body weight of steroids. And then you taper it down, see the response, probably the first couple of weeks by 10 milligrams or so, and then see the response, and then probably you can reduce it much slowly, say 5 milligrams per week, or later 2.5 milligram per week. And if they are tolerating the medication well, then keep them on a very low dose of steroids for a longer period of time.
and once again the recurrence starts, you have to start again.
No other option, sir. Yes.
So was it incidental? Beyond the joke.
Yeah, but then I think since trauma is a very important cause for sympathetic ophthalmia, and outdoor activities more with males, probably that's the reason why.
Okay.
I'm not being.
I understand, absolutely.
There's no gender bias.
Okay. Any more comments or question? Otherwise, we'll move on to the next.
Just one thing, Dr. Kumar, yeah, you talked about steroid 2 enough, say 2 weeks, and then follow up. But azotherapies should be continued for 2-3 years, or they can be stopped as well?
No, they can be stopped for depending upon the patient's response. But to be truthful, I have shifted from azathioprine to mycophenolate mofetil now, because that has got a better safety profile. And the only rider initially was the cost, but now the cost of mycophenolate is almost equivalent to almost that of azathioprine. So you can use mycophenolate mofetil.
Thank you, Amitabh.
Thank you, sir.
For the excellent presentation. So we'll move on to the next presentation by Dr. Sudipta Mitra. When she forgot to wear her glasses and missed a PCR, so she will be talking on PC rent going amiss.
Thank you. Yeah, first of all, thank you, AIOS Scientific Committee, especially Dr. Namrata Sharma, for letting us have this session in the AIOS. It is always a pleasure talking on behalf of your society, OSWB, in a bigger platform like AIOS. My topic is PC rent after IOL insertion. Should I Sir, can I start? Yeah. Yeah, so that's it. There's an audio. Please play the audio. Please play the audio. Acha, nahi aa raha hai. Acha, so let it go on while the audio comes. So I'll speak. So it's a diabetic, highly diabetic patient. So I just wanted this to be shown. Please lower down the volume. Lower down the volume. And she just got controlled. It was a cataract. Was waiting for 1.5 years. So, and it wasn't topical. So we were a bit careful, but again, we were quite confident. The last case of the day for me to relax after a long list. So every step, we were very careful. We did proper hydrosection, proper rotation. I was planning a direct chop. So all the steps that could actually save you were done for a hard cataract. As you can see, while I crack, the center part is quite leathery, and but I made smaller chunks so that I did not hit anywhere the zonules, and there was not creating any pressure anywhere, but and was using sufficient amount of viscoelastics with no financial interest. It was a viscoat, and as you can see, the central core came out separately, and there was sufficient good rotation, no effect on the anterior capsular margin, and as you can see, there was literally nothing behind the cataract, nuclear cataract. So I used cohesive viscoelastics to push it down, the post PC, and the smaller pieces were taken carefully. As you can see, I had also changed my instrument so I don't hit the PC, as there was not much support behind. And the last piece was done. I was very, very happy. In seventh heaven, I have done it. And smaller bits that were remaining were removed, epinucleus, and it was a very, very clear. Now I was planning to put a single piece IOL and So again, whatever was remaining, thoroughly done. Everything looked absolutely fine, and here it is. As we were pushing the eye well inside, I felt there was a bit of surge, but I let it go in the bag, and while I was doing it in irrigation, and I noted the eye well slightly tilted, but finally I realized it was not just tilting, it was actually tilting, it was going down. So I first of all tried to manipulate and find out why, and then I realized there was a rent somewhere which I had made I don't know when. So I took it out into the anterior chamber, and I had to look out for vitreous. So triamcinolone as the teaching goes, and then a vitrectomy to remove any tags that would be there on the eye well. So everything was done. And finally we planned to explant this single piece and implant something different, as the teaching goes that you should always explant these eye wells. And I repeated the triamcinolone for the purpose of time. I'm showing it less, but I'll proceed it a little bit. Finally, we had to explant the eye well. So here we used a Dodic method. We went up to 2/3, cut it, and then dialed it out one by one. And then we again checked for a vitreous, and we were planning for a multi-piece eye well now. I checked for the anterior capsule and found that my rhexis was intact, thank God. So this is how we use the multipiece injector and the multipiece eye well, and after that again we used triamcinolone to check if the vitreous was there anywhere and the eye well was placed. And finally we made a PI. Unfortunately it was a little big, but at least we could save the day, and finally this patient is doing fine today. So thank you for patient hearing. At the end of this I would like to say it was a VIP patient, at least very VIP for me. She was my relative. So that's it. Yeah.
Thank you. Any comments?
Well managed, but before implanting the IOL, I would also like to, the pupil was coming down, it was
Yes.
becoming small. So I would like to first see if everything is fine, because where am I injecting the IOL?
Yes, I did check.
Is it in the bag
I
or
did
not?
check, because if you saw it, I used the Irish repository. I actually showed it. I made a check. I showed it in the
Later
video.
on.
No.
But first time before
No. Before. Oh, before the first
injecting
IOL.
the IOL,
Single piece IOL.
single piece
You're talking
IOL,
of
we
a single
need to
piece IOL.
check that are we good to go, because
Actually,
the pupil
when the
was becoming
irrigation,
small.
Yeah, you're right. You're very
Right.
correct. But when you actually push in fluid and you don't see any instability in the anterior chamber, so it's difficult. I think I did not have the rent then. I went back, I saw the video again and again, and what I realized is when I was sending pushing the single piece IOL, there was a surge and it went and hit the PC. That leading haptic, it went and hit the PC. That is where I did the problem. I created the problem. This
Yeah,
might be the most common and most, I think. Yes, Shubhanda. Yes. Okay.
Yeah.
Can you please speak in the mic? Can you please speak in the mic? Mic. Yeah. Yes.
So on hindsight,
Yes.
would you consider, if you critically analyze it, that had you not used hydroimplantation and done the implantation of the viscoelastic, the chances of PCR would have been less?
Yes, sir. That is why I made the
I think
last
that
comment.
that should be the
That
take-home
was the
message.
last comment.
If you have
that this
the
was
time,
VIP. If you have the time,
and even if you don't have the time,
no, sir, and
how
especially
much more time does it take?
Not only that, when you are a bit tensed, I would say that when you're a bit tensed, and especially with cases which are price cases for you, it's better to go. There's no need of, it does not actually save time, because ultimately it took much more than what I had planned.
Yeah,
So it's
another thing
better to
is-
go for a viscoelastic, So better to put a viscoelastic, let your anterior chamber be sufficiently there, and then put the IOL, rather than go for irrigation, try to save time. Does not really help, because ultimately.
Well,
Yes,
And
of
did
course. You talk in the mic. Yes.
And
yes.
did you bring down the pupil at the end of the surgery? Did
Yes,
you
of
put
course. Yes, of course. As you
intracameral-
could see, I did bring down the pupil. I saw that it was round to understand that there were no more vitreous tracts anywhere.
And did
that
you
is
suture the main port?
no, here I didn't, because I found that the chamber was bent in sufficiently. I did press on the port, and the way how we test that the chamber stability is good. So yes, yes.
Any comfort to you, if it's any comfort to you, even under viscoelastic I ruptured my posterior absolute
Thanks, sir. I think Siddhartha, yes.
Yeah. Would you prefer a pars plana vitrectomy in this case?
Yes and no. See, I'm an anterior segment surgeon, so it's a controversial topic. For me, this was easier. So,
Dr. Chauvin, do you mean to say that we should not go for the hydroimplantation?
Yes, emphatically.
I think let's take the hands from our.
Hands don't matter.
No, it's
Ask
okay.
The patient. Ask the patient. Ask the patient.
No.
Ask yourself if you were the patient, what would you have said? What would you have
No.
said?
What I am saying, hydroimplantation does do well in more than 99% cases.
so can I just have a talk? Just a second.
0.01 is the one which matters it's in your head.
Let's just make it this way, sir.
even
I
with
think it
this
was
one
a
you said
surge.
it can-
Shugato,
Yeah, it was
Shugato,
the
it was
surge.
a surge. So what I usually
I
do,
beg
I'll
to
just
differ,
share.
I think.
Yes. Just a second, sir.
Is much more controlled in a viscoelastic environment.
Yes, of course. So, Shubhendra.
That is always there.
When I ruptured, it was because of the iron shooting.
Shubhendra, 1 second. I think it was the surge, and it usually happens when you are doing it in the vac mode. This was my defect that I would like to share. Just a second, since we
Only
came up
thing
with
is
this
that-
topic. Sir, just a second. I just like to share one thing, that I was wrong in one position, because there was a surge because I was doing in vac mode. So nowadays, burning my fingers here, I do it in the next phase, the visco phase, where the fluid going in is sufficient. So this is one point where, agreeing with what Sharazda says, sometimes with toric IOLs, we do so that we don't have to suck out the viscoelastic. So we can do it in the viscous phase so that the irrigation is more.
In the hydroimplantation, the mode is on the
I think we should move on.
So, thank you. Oh, sorry, Rudra had a
Yeah, I have a
banding-
question to Dr. Siddhartha Ghosh. He was telling that in those people, those are coming down. Is it a standard practice to see the periphery and then put the IOL?
You're doing it under hydro. So in hydro implantation, if the pupil has come down, you are not sure where you are placing it. It could be in the sulcus, it could be in the bag. And that is how, if you are not sure, how can you just inject? So it's
No, but
best
if
to
you are
look
doing a
at-
hydroimplantation, if you want to see the periphery of the bag, then you have to put some visco and only you can.
No, you can use the irrigation.
Okay. Is it your advice to do it in all the cases that in those cases?
My only point was, whenever you inject an IOL, please make sure where you are putting it. Unless your visibility is there, don't put an IOL.
Okay.
It can go anywhere.
Thank you.
So we'll move on to the next.
Take home is don't keep the patient, it is a catch case, keep it at the top.
Doesn't matter.
Doesn't matter. হাত গরম করে নিয়ে তারপর করতে চেয়েছিল So we'll move on to the next speaker, a very well-known glaucoma specialist, Devashish Chakraborty, who is now tackling his computer at the moment, and then he will speak on tackling the stent. A lot has been spent.
You have it on a pen drive. You have it on a pen drive. Pen drive আছে?
Yes. So we will go ahead with the next management, and this is very tricky because this device is becoming very popular nowadays among glaucoma specialists as well as cataract surgeons, but it's a very costly device, and if it's not implanted in the proper place, it will not act. So more than 1.5 lakh of rupees, you cannot take a chance. So the eye stent inject is becoming very popular. It's an MIGS device. We know it's a very small device. In fact, it's the smallest device that's implanted in the human body, only 0.36 millimeter. So it has 3 parts. It has a head that is supposed to be implanted within the Schlemm's canal, the thorax which lies in the trabecular meshwork, and there is a flange which lies in the anterior chamber. So the current device is known as the eye stent inject W. W stands for wide. So wide flange makes it easier to visualize. Then it comes in this injector. There are 2 stents which are preloaded, and there is a needle-like thing, that's a trocar. And then you have 2 buttons here. This blue button is for retracting the protective sleeve over the trocar, and the black button is for implanting the stent. Now, before any MIGS device, we need to have a very good look at the angle. So for this, we have to position the patient and position the microscope. So the patient's head is tilted 35 degree away, and the microscope is tilted 35 degree towards the surgeon. So this is quite unusual from the normal phaco position. So we have to practice this. Now this is the animation you see. So we go and touch the trabecular meshwork, make a small dimple, and press the button and inject the stent. Then move around 2 to 3 clock hours away and do the same procedure. And this is the actual surgery. So you need to master gonioscopy before this so as to get a good view of the angle. You can see that is the trabecular meshwork, the brown part. Usually it's not very difficult to identify because of the blood in the Schlemm's canal. So you inject 1 stent. A little bit of bleeding is common. In fact, that is good. It shows you are in the right place. You have to hit the collector channels, and then you move slightly away, and then again implant the second stent. So this looks fairly easy, but when you are doing it under very high magnification, there's a little bit of bleeding, the vision becomes hazy, then a lot of practical problems can occur. So problems can be with the visualization, with the placement, and we need to understand certain surgical pearls. So the tips are to turn the microscope and the patient's head as needed, to increase the magnification, to avoid bleeding near the incisions because the blood can go beneath the gonioscope and that can cause blurring of the vision, to apply the appropriate amount of pressure on the cornea, and to use the optimal type and amount of OVD. So you need to use high molecular weight viscoelastic for this. And the other tip regarding visualization is that we need to adequately tilt the patient's head away so that we get a good on-fast view. So this is the same patient. If the head is not properly tilted, we'll get a view like this. If it's properly tilted, we'll get a view like this one. And we have to attempt the target the nasal angle because there are more collector channels here. And the 2 stents are put 2 to 3 clock hours apart. We have to target either the junction of the ATM at PTM or the PTM itself. So we have to engage the trabecular meshwork and push against the posterior wall of the Schlemm canal until it dimples slightly. So you have to center the trocar inside the microinsertion tube, relax the hand, and squeeze the stent delivery button with the index finger. There are 4 clicks available. You cannot have more than 4 clicks. So 2 stents and 4 clicks. And you have to look through the microinsertion tube window during the stent implantation to verify that the stent is securely in place within the tissue before withdrawing the injector back. And upon release of the stent delivery button, a second audible click will indicate that the next stent is in position and ready to deliver. So this is the theoretical part. So we have to confirm the proper placement of the 2 implanted stents and ensure that each stent flange is visible in the AC. But the actual problem is, in most of the cases, there will be under implantation, at least in the initial stages. That is, the stent, you have already pressed the button, but it's not a snug fit. It's slightly loose. So what do you do in such cases? So here you can see from the video that the view is proper. You're getting a good view, and the surgeon is implanting the eye stent. He's going perpendicular, but as you can see, the stent is not fitting properly. So it is loose. So what you have to do is you have to rethread the stent. So this is a little bit of, it involves a lot of gymnastics inside the anterior chamber. So you have to rethread it. It's a very small device you have to do under high magnification. You have to put the trocar inside the central lumen, and only when you are in the exact place, you can implant it in the proper place. So now it is implanted. So it is sometimes the surgeon will miss a pulse because it's a very costly device, and once you're not in the proper place, it will not function. So let's see another video, similar situation. You can see that the surgeon has placed it, but it is loose, it's not fitting properly. So if it's slightly loose, what you can do is you can press it with the edge of the injector, and in many situations that can help you. So he's re-grasping it, he's trying to insert the trocar inside the lumen and putting it in another place, and this time he has succeeded. But sometimes, because of the haziness, because of the hyphema, despite repeated maneuvers, it may be difficult to rethread the stent inside the eye. So he has tried several times, but he has failed to restent it inside the eye. So in such situations, what we can do is we can first inject high molecular weight viscoelastic, and you can clear the hyphema from nearby area, and then you are using a microforceps and you are trying to retrieve the stent from the eye, and then you are trying to rethread it outside the eye. So you have retrieved with a microforceps, then you can put it in a piece of white sterile paper or the cover of the injector, and then you can put a dollop of viscoelastic, and now under high magnification you are trying to rethread the stent. So again, this is quite tricky because the main problem is the size is so small, you can understand it's 0.3 millimeter, and you need very good eyesight to do this. And then once it is rethreaded, you have 2 more clicks because the injector will have 4 clicks. So even if you have a missed click, there will be another click. So you now reimplant the stent to a different place. So the key thing, because it's a very costly device and it is only for a select type of patients where this will work, preoperative counseling is very important, where we have to explain the procedure, the cost, the insurance coverage. Hopefully it is covered by the West Bengal Health Scheme, and we have to discuss the pros and cons of surgery. And not only West Bengal Health Scheme, some of the corporate insurances also cover this. So we have to focus on realistic expectations from surgery. This is very important, because this is indicated only for mild to moderate open angle glaucoma. Remember, it's not for advanced glaucoma, because it will only shunt aqueous from the anterior chamber to the Schlemm's canal. In very advanced glaucoma, where there may be problem beyond the collector channels, it will not work. So for mild glaucoma, we may just eliminate the medications. For moderate glaucoma, we can reduce the number of medications. For advanced glaucoma, don't try this. You have other options like the GAT or the trap or the tube. So choose your patients wisely, promise less, and deliver more. Thank you.
Thank you. We'll take question, just quick comment from you. Dr. Mondal, if you can.
I really do not want to comment because I do not have any experience.
You can get ready with the presentation.
All your patients were only glaucoma patients, or you did combined cataract and glaucoma?
All my patients are combined patients actually.
Combined. Now the question is that when you say in mild glaucoma, you can reduce, you can be off medicine or reduce the medicine. Now in usual normal cataract surgery, the IOP goes down. Now what is the standard? Supposing IOP goes down by 4 millimeter in a normal cataract surgery, how much do you expect that it will go down post-operatively?
No, several studies have shown that it is the amount of IOP lowering is definitely less, and it lasts for a larger amount of time. Like if you do a normal phaco in a primary open angle glaucoma mild patients, also the patients will be, the IOP may be reduced by 2-3 millimeter mercury, but that is not long sustained. It will again come back after a few months or a few years. So with eye stent, the duration for which the IOP remains controlled is definitely more. That is there.
Thank you. So it is a great honor to have Dr. Anil Mondal to be speaking in our session, and he will be speaking on improved surgical technique for newborn glaucoma with axon-filled rigor anomaly. Thank you, sir.
Thank you, sir. Thank you for the opportunity. I like the title. survivor of the storm. The story of which I am going to present it's just not a mild storm, it's a serious cyclone. Story of a newborn baby, and the mother, I have permission for photograph, videograph and story to tell in this kind of forum, no problem. The newborn baby delivered out of cesarean section in the term pregnancy. The mother is an ophthalmologist, father is a gastrointestinal surgeon, MCH final year, and both the parents, grandparents were doctors. They are gynae specialists. They run a busy nursing home. Cesarean section was done because of the diagnosis placenta previa. They wanted to avoid complications and during the delivery, excessive bleeding. To avoid that, they did cesarean, and on delivery, you can see the appearance of the eyes like this. Serious issue, congenital glaucoma. Myself, I saw probably as a primary congenital glaucoma, but the child had neonatal jaundice. It was treated. After about 18th day of birth, I operated, and the response for surgery you will see in the video. Can you present the video? The video contains the commentary also. This is the clinical appearance of the eyes of a newborn baby with congenital glaucoma. The corneal edema reduced partially after 2 weeks of medical therapy with topical dorzolamide hydrochloride. Note the prominent Swalb's line and the iris hypoplasia in both eyes. A diagnosis of Axenfeld Rieger anomaly with congenital glaucoma was established, and the child underwent simultaneous bilateral primary combined trabeculotomy and trabeculectomy. What follows now is the surgical technique performed on the right eye. A limbus-based conjunctival flap was raised with blunt-tipped Westcott scissors and plain forceps. Hemostasis was meticulously maintained throughout the dissection of the conjunctival flap. We prefer a bipolar underwater cautery. A 1/2 thickness limbus-based triangular scleral flap was delineated, and a partial thickness scleral flap is then dissected towards the limbus using 15 number Bard-Parker blade. Surgical landmarks and the anatomy of the limbal region was carefully identified. A 3 by 2 millimeter deeper trabecular block was delineated without penetrating the anterior chamber. A central radial incision was then made across the scleral spar. The objective of this radial incision is to cut the external wall of the Slem's canal and to avoid entering into the anterior chamber. The internal arm of the trabeculotome was then introduced into the left of the radial incision, and it was rotated into the anterior chamber. The trabeculotome was then passed into the Slem's canal on the other side of the radial incision and rotated into the anterior chamber. The trabeculotomy part was completed, and then the trabeculectomy part was performed. A 3 by 2 millimeter deeper trabecular block was removed with the help of a limb forceps and venous scissors. A 3 millimeter segment of the prominent Swalb's ring was then removed. note the fundal glow and the ciliary process. The scleral flap was then closed with one 10-0 nylon suture at the apex of the triangular scleral flap. The conjunctiva and tenons capsule was then closed with a running suture of absorbable material using 8-0 polygalactin suture. .3 ml of dexamethasone injection was given subconjunctivally. The present surgical technique is improved in many ways. Combined technique ensures dual outflow pathway, single suture modulates wound healing, and removal of a segment of prominent swell-base ring protects Descemet's membrane from tearing. At the 2 months postoperative follow-up, there was complete clearance of corneal edema and intraocular pressure was under control in both eyes. Compare and contrast the clinical appearance of the eyes at presentation versus 2 months postoperative. The bleb appearance was satisfactory in both eyes. Primary combined trabeculotomy and trabeculectomy is safe and effective in this newborn baby of congenital glaucoma with Axenfeld rigor anomaly. All right, and we can stop. So before we come to the discussion, if little time is there, I just wanted to say 2-3 points. The child's history is, the child was born by cesarean section on 18th of 18th of November. We waited for about 2 weeks because of neonatal jaundice. It became all right. Our physician and the anesthetist gave permission for surgery. And by the time patient was kept on dorzolamide hydrochloride only, 2% 3 times daily, there was significant improvement in corneal clarity. But anyway, the surgery will be required. You cannot afford to keep on continuing medical treatment. It's a surgical disease. Waiting for 1 to 2 weeks in this situation is no issue. That is one thing. The other thing is simultaneous bilateral surgery was done. And with whatever experience I have, I felt that all the attempts should be done so that best attempt in the first surgery, because first chance is the best chance. Combined technique, I do not use mitomycin or 5-FU in the primary surgery. Closure of the scleral flap by one suture at the apex so that wound modulation will help in long-term pressure control, and removal of the 3 mm segment of prominent swell-base line hopefully will release tension on the Descemet's membrane, and in the long run chances of development of Habstai or the breaks in the Descemet's membrane will be not there. These are the 3 important points. Thank you.
Thank you, sir. because of the lack of time, we'll request Sudipta, Dr. Mitra to give the vote of thanks, and we'll have a quick group photos before we vacate the room.
Yes.
The same thing was done, exactly same thing was done for both the eyes.
We are extremely thankful to AIOS Scientific Committee, Dr. Namrata Sharma, for on behalf of OSWB, Ophthalmic Society of West Bengal, we thank AIOS, and we thank the chairpersons, the panelists, the speakers, and the audience for please gracing this session and making this session a success, and all the stalwarts and the beautiful comments. That was so interactive and so much of learning. Thank you so much, earnestly. And a quick group photo. All of us can join, please. All of you, please join.